Oh, there we go. Recording has started. I'd like to welcome everyone here in the room and also everyone who's joining us via webinar today to our patient and public engagement lunchtime learning series. For you guys who it's your first time joining, just to let you know that this happens every second Wednesday of the month at this time. Different guest speakers, variety of topics, so we're always happy to have you join. I'd like to start off this morning, first by acknowledging that we are gathered here today on Treaty 1 land, home of the Anishinaabe, Cree, OG Cree, Dakota, and Dene peoples, and homeland of the Métis Nation. In coming together today, we respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, recognize the ongoing present-day colonial violence that is faced by Indigenous peoples in our healthcare system, and we dedicate ourselves to moving forward in partnership in a spirit of reconciliation and collaboration. Oh, okay, we're gonna just got used to it. So first of all, I thought I'd go through our agenda. We are going to just quickly look at how we define and what is patient and public engagement before we move on to the good stuff. And today we're going to be talking about things that we don't typically talk about in patient and public engagement. That's bodies, feelings, emotions. We don't like to talk about that too much in research, but it's really important that we do, especially when it comes to patient and public engagement. So we're going to talk about critical reflexivity. We're going to talk about embodied reflexivity. We're going to talk about how to integrate it all. And we're going to also talk about trauma and embodied reflexivity. And then there's some key takeaways. If you don't know what reflexivity is and you're like, what are we talking about? Don't worry, we're going to go through it together. So first of all, when we talk about patient and public engagement, it's important just to be really clear about what we're talking about and how we define patient-oriented research. Now, a lot of people tell me, well, I do patient-oriented research. My research improves outcomes for patients. But that's not what we mean. There's actually 5 elements of patient-oriented research. It's seen as a continuum of research that engages patients as partners, focuses on patient-identified priorities, improves patient outcomes, is conducted by multidisciplinary teams in partnership with relevant stakeholders, and it aims to apply the knowledge generated to improve healthcare systems and practices. So it's important to understand that and that I like to underline with huge, it's because it's a combination of all of these 5 components that make patient-oriented research. And the Canadian Institutes of Health Research, the strategy for patient-oriented research, define patient engagement as the meaningful and active involvement of patients in the governance of research. So that means having people with lived experience on your steering committees on the highest levels of governance, and the priority setting of research. Remember, the definition of patient-oriented research is that we're focusing on patient-identified priorities. In the conducting of research, so people with lived experience actually involved in the conducting of research, and the knowledge translation of research. And another way that I like, another definition is by Involve in the UK. And they define public involvement in research as research that is carried out with or by members of the public rather than to, about, or for them. So that's a much kind of more simple way of looking at it. For me, the biggest thing is really looking and accentuating decision making, because that's what it's all about. So it's people, formal caregivers, and communities with lived experience of a health issue having a say in decision-making about the research process. And what that means is helping to identify research priorities that mean the most to people with lived experience. It means helping to shape and clarify the research questions that are being asked. It means helping to ensure the methods and the designs that are being proposed for the study are appropriate, are acceptable, and sensitive to the rural context of people who are living with the health issue, helping to ensure that research uses outcomes that actually have meaning for caregivers, for patients, for communities. helping to ensure that the language and the content of the information that's often provided to participants in research and studies is actually accessible, is actually appropriate in answering the right questions, helping to increase participation, recruitment in a research study, identifying a wider set of research topics or new areas of research, interpreting the findings, the research findings, then ensuring that research reflects the concerns, the interests, and the values of the public, and that money and resources are being used efficiently. And we know that there are many levels of engagement. These are the three core kind of levels of engagement. And again, it's all around decision making. So at the consultation level, which is seen as the lowest level of engagement, people with lived experience, friends, families, caregivers have a say in, they give their feedback and their input on the research decision, but researchers still hold a lot of the decision-making power. When we move to collaboration, this is where there's shared decision-making power. That means people with lived experience and researchers have equal say. And then when we go into patient and public directed, that actually means people with lived experience, caregivers, actually are the ones making the research decisions. They're managing the research project. And health researchers are more seen as the ones that are being consulted on different ways of doing research and how to conduct it. But it's mainly patient directed. So why are we talking about critical reflexivity? Well, a lot of times when we talk to patient and public partners, the biggest thing that comes out, the most important thing around patient and public engagement is relationship building. It's about trust. It's about understanding between researchers and people with lived experience. And in order to have that and to help build authentic and meaningful engagement, it requires that researchers themselves bring a level of self-awareness that may never have previously been examined before. So just to kind of differentiate between what's known as reflection, reflexivity, and then critical reflexivity. When we talk about reflective thinking, that would be thinking about the process and the parts of our research systematically, in depth, seeking multiple and alternative perspectives. When we talk about reflexivity, it's actually a state of thinking, but also of being, in which we strive to understand the ways in which one's own presence and own perspective influence the knowledge and actions which are created. So how that actually influences the research. And then when we talk about critical reflexivity, this is one little step further. And this is actually concerned with the social conditions of truth itself. So it actually looks at problems of power within research. And it requires that health researchers and patient and public partners have to start doing that critical reflexivity around their own social location and in which they inhabit. So when we talk about critical reflexivity, it's really about an understanding, first of all, of how our own personal values, our experiences, our interests, our beliefs, and our political commitments shape the area in which we research. And that includes how we choose to prioritize things, what questions we choose to ask, the way we design our study, the methods we choose to use, and the way we interpret findings and disseminate findings. We also have to look at how these values and these experiences relate to larger social and structural locations which you personally inhabit. So thinking about gender identity, gender expression, age, ability, race, class, ethnicity, ability, sexual orientation, immigrant status, religion, all of these things, as well as larger processes of power and oppression. So colonialism, racism, patriarchy, capitalism, heterosexism, ableism, all of these things. So it requires of us to actually think a little bit larger of how we are situated within systems of power and oppression. Sometimes the unearned privilege and unearned advantages that we receive based on our social location, and also sometimes the unearned disadvantage because of our social location. So we talked about this last time, Which is a little bit of a refresher. We went through some of these questions. So the first, when you start off with your research, always thinking about what your own personal values and experiences, how they impact the area of health that you're going to be researching, how these personal experiences relate to larger social locations and processes of oppression in the area of health that you're researching. Then what are some of the personal values, assumptions, perspectives, and experiences with regard to the people living with the health issues that you're going to be involving and engaging in your research? And what current health inequities exist with regards to the area of health which you're going to be researching? How do you think people with lived experience prefer to be engaged? And what types of challenges and barriers might people with lived experience confront in order to come to the table and be? How can we become more aware of and take advantages of opportunities? And I call it opportunities because when we are able to actually create a safe enough space where we can challenge each other's ideas, resist and renegotiate power within a research team, that is the ultimate thing. Oftentimes researchers say, oh yeah, we engage people and it went really smooth. That's when I wonder, have we created a safe enough space where people can actually challenge, where we can address it and say, wait a minute, there's a power imbalance here, we need to address it. And then resiliency, this is a key part that we don't talk a lot about, but also how do we support strengths-based resiliency? What does it look like? What does it feel like? And what does it sound like? And how do we support it within our patient-public partners and the research process itself? I also always bring this back. It's important to create safe spaces to think of how the issue of trauma may impact the area of health that we're looking at. I think it's important to think about some of the ways in which we can ensure that safe spaces are made within a research team and have those conversations frequently. Almost every meeting, we talk about safety. It's important. What does physical safety mean to you, look like to you, feel like to you? And that means researchers as well. What does it mean to you? What does emotional, psychological safety mean to you, look like to you, feel to you? Now, we're going to get into embodied reflexivity. So we're going to go to another level. The interesting part of it all, when we talk about critical reflexivity, is there's actually two different components, and we often overlook embodied reflexivity because it's a little bit more difficult to get into, but it's equally as important. So when we talk about critical reflexivity, which we just did, a lot of it's around language and symbolism and how it's associated with systems of power and oppression. But when we talk about embodied reflexivity, we're actually looking at how researchers' physical presence and performance can actually influence patient and public partners' sharing of their experiential knowledge, and in turn, the production of knowledge. So it's about looking at the materiality and the experiences of the body. And that includes health researchers and understanding the story that's told through our own corporality. So the important thing is, when we start talking about embodiment, it's understanding how the role of embodiment plays out in different circumstances, especially within patient and public engagement. So in the construction of particular narratives, a number of theorists have talked before about how the lived body is produced by the social and cultural discourses that are reinscribed upon the body's surface materiality. So Judith Butler, who is a post-structuralist queer theorist, talks about how when a baby is born, when is the baby a boy before someone proclaims it's a boy, or how does discourse influence body materiality? So the one thing that we don't always address when we're engaging is oftentimes social and cultural discourses in relation to systems of power and oppression are used to other people. So that means constructing a binary between worthy bodies and unworthy bodies. And we don't always think about this, but it's really important. So for example, these are only a few kind of illustrations. Think about how laws, policies, government, media, public institutions shape the dialogue and conversation around things like illness, disability, and aging. Oftentimes when we talk about illness and disability, we talk about the body failing, the failing body, in need of fixing, or sometimes when we talk about aging, the invisibility that people feel as they age as well, in our discourse, the way we look at things. People with lived experience of disability often say that within healthcare systems, they are seen as something that just needs to be fixed versus seen as people who are just differently able. So understanding how those discourses frame the way we perceive our own bodies. When it comes to racialized bodies, there's an amazing theorist everyone should check out. Her name is Dr. Shireen Razak out of the University of Toronto. And she talks about racialized bodies as spaces where violence can occur with impunity, without consequence. So if you think of, in the context of Canada, missing Indigenous women, or if you think about policing, stories of carding, harassment, and murder of people of color, you start realizing that sometimes there is this social construction within discourse that others. And then gendered bodies, oftentimes it's seen in discourse as places in need of constantly policing in order to keep the illusion of man and female. So if you think about in the idea of rape culture, women oftentimes are having to police themselves, having to police each other, because there's that idea that if women's bodily performance, the way they dress, the way they present themselves in some way brings on sexual assault and violence. Also, when we think about transgender bodies and rights, we think about how the medical system, if you want to get surgery to transition, you oftentimes have to be diagnosed with a mental illness called gender dysphoria identity in order to get the procedure. And oftentimes people who live as transgender, who identify as transgender, say, there's nothing, I don't have a mental health issue, I simply want this surgery. But they have to change the way they tell their stories about their bodies because of this to get through the medical system. So understanding how bodies can construct particular narratives. Differing body sizes as well. There's a lot around this, right? Seeing that different body sizes are often seen as culturally or symbolically out of bounds and unable to conform to these neoliberal rationalities around thin and healthy citizenship. And some of the stigma and the language that's associated with the label of obesity that's attached to completely unrelated character attributes like laziness or lacking willpower. So understanding the stigma that comes around these narratives of bodies. And so what does this have to do with patient-public engagement in health research? Well, frequently the involvement in health research is predicated on patient-public partners sharing their experiential knowledge with health researchers and the research decision-making process. And this includes patient partners disclosing experiences of their personal and physical interactions with their environments. But this imparting of knowledge may be made in context that juxtaposition these falsely social constructions of the failing body of a patient-public partner versus the research, the vibrant physicality of the researcher. So understanding those silent pieces underground that can juxtaposition this sharing and this storytelling, and that can often silence one voice. So when researchers and patient-public partners bring an insight and an awareness of their own physical presence and how they interact with the environment, it can make a significant impact on patient and public engagement. Once researchers and patient-public partners begin to collaboratively work towards challenging, disrupting, and troubling those socially constructed binary categorizations of worthy versus unworthy bodies, by being aware of how their own bodies play a role in the interactions of teams, then they can start to co-create research that works to dismantle these kind of normative discourses that seek to other people And in turn, it actually challenges a lot about the othering that quite often happens in patient-public engagement. In traditional engagement approaches, oftentimes there's the researcher and the patient-public partner. But sometimes you can start to create, when you acknowledge and have insight and awareness into your own physicality, you can start to create spaces of mutual embodied interaction, which is pretty cool. And research shows that trust is built upon two people, built between two people through the incremental mutual sharing of vulnerabilities, which is pretty scary as a researcher to start talking about vulnerabilities, about awareness, about bodies. But this needs addressing the sometimes impervious silences that can happen in which bodies can exist. And addressing that in the ways that bodies can sometimes silently impose power, right? In social media, you always hear the term man spread. So people who identify as a certain gender may take up more space than people who identify as another gender. We also think about whiteness and how we don't think about that as far in terms of all the other privileges and advantages that come with it. And bringing this to light means working to ensure embodied silences can't negatively affect a research relationship. So how do we integrate all of this together? Well, first of all, it's about being aware of one's own emotions and bodily state. We don't typically ask researchers to think about the impact and experiences of their own body. But bringing the body back into research and back into patient-public engagement means taking risks to be accountable to how knowledge and experiences, including those that are cultural, social, and emotional, are lived through the body. It's important for researchers to start examining bodily experiences that are outcomes of exchanges between patient-public partners and themselves. So sometimes I've had situations where researchers after an engagement activity will say, I'm really tired, I'm just worn out. Sometimes it can be in relationship to bearing witness to patient-public partners retelling of a traumatic experience. So a researcher understanding how their body reacts and how they feel after these experiences is an important thing. Vice versa with patient-public partners, understanding to certain feelings that come out in a research patient-partner interaction and what that means for the relationship as it begins. And being more conscious of these kind of reciprocal exchanges of bodily experiences, an empathic connection can be formed, which is foundational to creating trust. And affect and physicality can help us to understand the realities of oneself and others, and become the entry point to some deeper insight and understanding of each other. So understanding what these emotional and bodily states actually reveal about yourself and others is important. Emotions can provide significant feedback about the environment in which people are situated. So their embodied experiences can reveal how bodies are entwined with the experiences of others. For example, a researcher feeling anger as a patient and public partner recounts a frustrating experience with the healthcare system. These emotions are a result of actually being present and listening to a patient partner's story and experience. And the researcher's response actually validates and acknowledges the disappointment and the exasperation a patient-public partner must be feeling. This demonstrates how emotions are never an individual thing, but that they're in relation to one another. And the way in which the researcher uses their voice, how they themselves are present, and even where they sit in proximity to a patient-public partner has an impact on the engagement process. We also have to acknowledge non-verbal communication and how it contributes to the co-construction of knowledge. So there's something called body memory, and that's perhaps practice or performance that has been embedded in a researcher's corporality can be cued by physical and emotional social interactions between researchers and patient partners. So, for example, if a health researcher formerly used to be a nurse or a social worker, they may actually bring about a certain affect in relation to the patient partner telling their experiential knowledge that's embodied from when they used to work as a nurse. So there's different ways in which we don't even think, but we interact and we cue ourselves. It's important that we all recognize that both health researchers and patient public partners our identities are multiple and they're complex. We carry and we embody a complexity and history of lived experiences and identities that are inseparable. And in order to be truly embodied and reflexive, researchers, it's important to understand and to begin to challenge the idea that this illusion of value-free, objective, and stable state research, as well as the notion that you're simply a researcher when you come into these relationships. You also bring and embody a whole lot more that we may not normally address. And it's also important to appreciate how socially constructed difference can impact on the interactions between researchers and patient public partners. So there are moments when a researcher confronted by their body that draws attention to how difference is constructed and lived. So facing race, culture, ethnicity, age, gender identity, even the space that one's body takes up. So these are all ways in which researchers can understand how their social location is inscribed upon the periodicity of their body and how it influences the direction of knowledge. So a lot of times we always just start out with how does my physical presence and performance influence sharing experiential knowledge? Those are some of the questions that we start with. Now, when we think about embodied reflexivity, it's important to address trauma as well. I talk a lot, everybody probably knows that I'm big on trauma-informed practice and engagement, or trauma-informed engagement, because I think it's really, really important. Trauma, which is defined as experiences that overwhelm an individual's capacity to cope, is a widespread, harmful, costly public health issue. And yet, oftentimes when we're developing a patient-public engagement strategy, health researchers overlook the fact that the experiential knowledge that's being shared by patient-public partners may be intertwined with experiences of trauma. And evidence shows that patients in primary healthcare systems a lot of times have significant trauma histories, which can impact everything from their physical and their mental health, their responsiveness to health interventions, and their ability to access appropriate healthcare services, and hence even identify as a patient. Therefore, it's important to make sure that any type of engagement practice includes a trauma-informed approach from the very beginning, from the recruitment stage to the selection of participatory approach, very important. And the 4 principles of trauma-informed practice are having an awareness of what is trauma. That's so both health researchers and patient public partners understanding what is trauma, an emphasis on safety and trustworthiness, opportunity for choice, collaboration, and connection, and a strengths-based and skill-based, and skills building. So when I talk about trauma awareness, it really means that everyone's on the same page and understands the commonness of trauma experiences. Also, that everyone understands the impact of trauma and how it can be central to a person's development. Also, the wide range of adaptations people make to cope and survive after trauma. And I say the word adaptations, and that's actually a strengths-based word, because sometimes we might say symptoms, or we might classify or medicalize or label something that's an adaptation that people are using to cope and survive after trauma. And then there's the relationship. Understand that there is a strong relationship between trauma and physical health and mental health. And when we talk about safety and trustworthiness, It's about physical, emotional, and cultural safety for patient-public partners and researchers, and it's a key aspect because oftentimes survivors may feel unsafe, may likely have experienced an abuse of power within a really important relationship. So we need to talk about power imbalances when we come together as patient-public partners. And may currently, some people may be living in unsafe relationships or unsafe living spaces, and it's important to understand this. Safety and trustworthiness is established in multiple ways, but sometimes they're even just simple, straightforward ways. Welcoming introductions when we first start things out, adapting the physical space to be less threatening. So talking about if there's been trauma within the healthcare system, you're probably going to have your meeting off site in a place, meeting people where they're at versus making people come to a place that may symbolize trauma or previous experience of trauma. Providing clear, accessible information about the entire process, walking people through what the project is, talking about confidentiality. Creating a crisis plan. This is something we don't normally think about when we're creating an engagement strategy, but it's really important to understand, to always have on hand resources that can be given to someone. And when I talk about resources, like mental health resources, think about free, accessible places. So places where you know there can be drop-in mental health services that are free, phones and are free toll-free lines and stuff like that. Having those resources on hand, having a little bit of an idea about grounding techniques and things like that. So if someone is triggered during a session, that you can talk to them a little bit about breathing, about centering, about coming back to the present, and being able to just come into an engagement understanding how to look at, to be prepared if someone does have an experience or a trigger. Demonstrating predictable expectations. These are really important things around safety, making sure that you have very clear expectations and scheduled meetings. Like these all things make people feel safer when scheduling meetings on a consistent basis. There also has to be an acknowledgement for health researchers as well, that there can be vicarious trauma and burnout. That even if health researchers have never experienced trauma before, there may be a trigger that comes up by a response or a reaction or behavior. So understanding yourself as well. And those key elements is around making sure that you have policies and activities that support both the self-care of researchers and the self-care of patient-public partners. And they call it ABC for vicarious, so awareness of your own needs and emotions and limits, balance between work, leisure time, and rest, connection to ourselves, to others, and something greater. So understanding within yourself, having that self-awareness too, for coming into engagement. Always offering an opportunity for choice, for collaboration, connection. So self-efficacy, self-determination, dignity, personal control, allowing people with lived experience to have choices on how they prefer how they would prefer to be heard and to be voiced, even if they. So researchers always trying to communicate openly and honestly, always being aware and addressing power imbalances within the relationship, allowing space for the expression of feelings without fear of judgment, providing choice as to engagement preferences, and working collaboratively with patient-public partners. And strength-based means that we should always be trying to help on both sides, I think, because a lot of times patient-public partners can also help researchers identify some of their strengths and how to develop resiliency as well. It's a two-way street. And teaching and modeling the idea, skills about recognizing triggers, grounding, calming, centering, and staying present. So having those honest conversations. And the biggest one, of course, is know yourself, right? So So understanding what you bring to patient public engagement, your own story, your diversity, culture, beliefs around things like trauma, around those. So what are my underlying assumptions about the experiences of those who have experienced trauma, how people recover, how might this belief influence my engagement with others? What particular responses or behaviors of people I'm engaging might trigger me? So understanding me as well, what triggers me, how do I know when this is happening and how will I respond? And then there may be experiences in my life that could influence my ability to do trauma-informed engagement. How am I managing? What am I noticing in my body? One of my favorite, I always read her, Brene Brown. She's a shame researcher, and she always talks about when we start feeling certain emotions around shame, that we have these physical reactions, and one of them is tingling in our armpits. And I always thought that was funny. And then I was having an experience once where I was talking to somebody, what is that? My armpits are tingling. So understanding, sometimes we have these funny physical things that come about when we're feeling certain emotions, and just recognizing them and noticing them. Are there areas in my life that I need to pay more attention to, and who can I turn to for support? So thinking about those things too, as whether you're a health researcher or a patient public partner. So some of the key takeaways from everything is, I guess, first of all, the body discloses. So embodied research, embodied reflexivity means reflecting on the very presence of both researchers and patient public partners' bodies within the research process. And the erasing or the erasure of researchers' bodies from conventional accounts of patient and public engagement in health research actually negates and obscures the complexities of knowledge production and yields a really deceptive, tidy account of what patient and public engagement is, right? If we ignore researchers' bodies. Understanding on the body is the prime site of silences. So to reflect upon bodily presence and interactions means to address the elephant in the room. And beginning to examine silences and omissions in the research process, we can begin to critically examine how bodies are sometimes put into these binary constructs, and how we define illness, how we define disability within our social context. And it's important to address the role of silences and omissions in patient public engagement around issues for everything from sexuality to gender to race. All of these things are important. And in each research encounter, silence can inform, it can restrain, and it can facilitate what is said and what is not said. So understanding this importance. And then finally, self-care. Self-care plays an integral role in patient and public engagement. We don't talk about it a lot, but it's important to discuss self-care strategy. Sometimes when we do engagement activities, we end the day by talking about what are we going to do. Name one thing we're going to do tonight that we're going to do for ourselves. What kind of self-care thing? And it can be going for a walk with our dog. It can be eating a healthy piece of fruit. All of these different self-care strategies. But having that discussion as a group is a really great way of kind of coming back and grounding the conversation at the end. It could be a heavy conversation. So just bringing it back to self-care, because the reality is with patient and public engagement, you can't facilitate and support and engage with each other if you haven't looked after yourself, first of all. So that is, we're talking, it's a lot of information, I know. Any questions? Yes,
I don't know where to start because there's so much. Who's sort of leading the charge in developing this literature on embodied reflexivity and what area do they come from?
Well, it's interesting. A lot of qualitative research, a lot of the social sciences talks a lot about embodied reflexivity in relation to researchers and participants. So when you're interviewing them, So a lot of what we talked about today, I've actually taken and kind of transferred because we don't really talk about it in the context of patient public engagement. So we're hoping we've created a trauma-informed framework that we're talking to different people about different communities, and we're actually going to present the findings pretty soon at KT Canada. So that's one of the ways, and some of those conversations around the strengths-based, around some of those embodied pieces are definitely things that have been brought up in community around patient public engagement. So it's exciting. Yes.
So in that framework, like, will there be, so I guess I'm thinking, what's, like, where do I go? Like, from here, like, would there be plans for, like, I could see it being really helpful for wanting to do it, but almost like needing like a script, to start, and checklists of certain things to help me when I'm doing it, to that I'm saying the right things, or opening the meetings and closing correctly, and that.
Absolutely. And we've been starting to create some of those resources and tools, like little guidebooks on how to address safety at the beginning of your meeting, how to talk about self-care, and also how to address a disclosure, which is something that we don't typically talk in patient public engagement. I think we often think, oh, somebody's going to come and they're going to share their experience, not realizing that their experience could get triggered, things could happen. And the importance of being able to be able to then manage and help somebody along the way. So we are definitely trying to build some of those sheets and those ideas, and perhaps even some online and have that conversation, because it is something we've been doing kind of as we go along with advisory groups and getting that feedback to within the project of the best ways to do it as well for communities.
This is more of a comment, but an advisory group I help out with, sometimes that's pretty emotional, and I'm gonna ask you what people's drivers are for part of the group. It often has to do with like being other people with experience. And so there's been like conversations around is part of this a support group? This isn't a support group. We're focusing on the research, and so it's a really interesting thing to kind of reflect on, is that it almost seems like multiple things. So getting together could be seen as a support group. Maybe that's not the only thing, but I don't know if this creates more space to acknowledge that, or if anyone else has had that experience, but that seems to be like a big piece of it, even though it's not even directly related to our research process.
And the importance of creating that space that people can talk about what they're going through, because it has to be a mutually beneficial relationship, right? It's not just people's experience helping make research decisions, but also, okay, what are they getting out of it? And perhaps sometimes what they need, or what people need at that time, is just some emotional support, being able to connect with other people who have gone through similar experiences, and allowing for space. And that means being adaptable, being flexible. That's one of the big things with trauma informed, is being able to adapt. Sometimes something's going to happen in your meeting and you're going to have to push aside. And we're used to, a lot of times, I think in health research, we're used to having this agenda, and we have 10 things we got to get through, and something goes completely to a different space, and being able to allow for that space for the who are contributing all their time and all their knowledge. So sometimes they also require. Oh, Amanda.
We have a question online.
Yes.
Are there any resources we recommend share to researchers about embodied activity that we can share before they incorporate patient engagement?
Yes, I think that was kind of goes to your piece. There's definitely a few, and maybe what I'll do for our wonderful person, I can put some resources around trauma-informed practice, and a few bits on embodied reflexivity. There's not a ton on embodied reflexivity within patient and public engagement, but we're actually starting to come out with, because there's some key questions and some key things that I know I always do in practice, and I know that I've learned from a lot of our other patient public partners along the way of what they really appreciate as far as engagement, that I definitely can kind of put together for a resource. We have some blog posts too on embodied reflexivity we have a blog called Knowledge Nudge, and it's on Medium, and it has a few different blog posts on the importance of embodied reflexivity and some of the questions you need to ask yourself at the beginning. So I can also perhaps post that under the video, or if you put your email address in the box, then I can send you some more information for sure. Yes, Lisa.
These lunch and learn sessions are great. I know you have a lot of online tools, that huge resource you have.
Yeah.
But do you guys do like a workshop, or like, so I sometimes feel somebody who's done this will kind of throw in and feel unequipped and not doing the justice to the people who are coming to these groups. Like whether there's I wonder, you know, if there's like a half day or whatever, a workshop where you feel like you can come away with some type of certificate or something to start, you know, that you and that other people when they start, you know, working in this area, that they can learn, sort of get some, that makes sense, like a workshop or some certificate.
Absolutely. We had a conversation around having some different organizations teach trauma-informed practice to come in and do a half day for health researchers, because a lot of times health researchers don't even think I need trauma-informed. So that piece we're going to try to get organized so that you can integrate. And also, I think, yeah, as we discussed, maybe there is that possibility of doing a little workshop on some of the key things around having an advisory group and some of the questions that you need to think about and develop along the way. But definitely we have been trying to get some informed workshops together, but also some more tools around how we can integrate this a little bit more into our practice. Because it's definitely something that's kind of not taught a ton. And I think we've talked about having that do online modules, but definitely we'll post it.
Even like role, I do not like role like that kind of fight,
But it's
I'm like first to go in the corner. But when you do it, it like does help with sort of practice.
Here are ways to kind of, words to say, things to kind of statements that can express an acknowledgement of what one's going through the ground or their own. There's lots of ideas. Any other questions? Great. Well, thank you so much for coming today. This has been recorded, so it'll be up on our YouTube channel for access as well. And definitely feel free to email me anytime or tweet me, whichever way you want to contact me. If you have any questions or concerns or anything, I'll be there. Thank you so much.